The running order for today for the webinar from the University of Warwick, the MSc in Diabetes Care. The running order, first and foremost, is Dr. Amjad Salman. He's from Qatar, and he will just be telling you a little bit about his experiences on the programme. And Diarmuid's going to ask him a few questions. And then we'll hand you over to Dr. Colin Kenny, who's the programme director of the programme. Hi, Colin. And good to have you there. And then I will finish off with a kind of a programmatic overview where you will find out about the modules, pricing, and just what to expect in the day-to-day setting on the programme. So that's the running order, and feel free to interrupt and ask any questions you want. And if you're feeling shy, there is a little chat button on the bottom of the screen as well. So you're very welcome to ask us by chat as well. So over to you, Diarmuid and Amjad.
Brilliant. Thanks a million, Rebecca. So everyone, my name is Diarmuid Brannock. I head up the academic affairs section in IHED, so I'm looking after all the education delivery of the programme with Ian and Colin. Amjad, look, thanks a million for coming on board to have a chat today. Really appreciate it. I guess the first question really is, what drew you to the programme? Why diabetes? Why this programme?
Hello, everybody. Thanks, Rebecca, and thanks, Ian, and thanks, Colin and Diarmuid, for all your help and support during this year. I graduated from the Netherlands, so I worked for quite several years there. And 7 years ago, I moved to Qatar. And as a family physician coming from Europe, I had little confrontation with this large proportion of patients with diabetes. So when I came in, I got extra courses and some introduction help and from colleagues and everybody. I got deeper in the diabetes, but after a while, I felt the need to go to get the science in a regular way. And to be honest with you, I started with another diploma in Cardiff, so where I did 3 modules, but the other diabetes diploma was for a secondary line, so I didn't feel that it just suits my needs. And then you came along in Qatar, I remember 15 months ago, and then you gave us this lecture and how is this diploma is just for the primary healthcare, and then I saw the benefit of it. And that's why I got to your program. Sorry for talking too long.
No, and I suppose that, what differentiates the program is, it's the focus on the kind of total patient management. And Colin will speak a lot more on this, but it's really looking at everything from, population screening and initial diagnosis, and then making the right choice about how the patient is managed, and then empowering the patient to take more on themselves. What difference can you see in your patient care so far?
I can give some examples. During the course, you get to know the medication better, and then you get to know, for example, that some drugs, fenofibrate, for example, are better for retinopathy, and then you get to know, for example, what you expect if you confronted with a patient who after getting better control of his diabetes loses weight. Because now we are doing the last exam, so we are reviewing everything. And what I like, the best part of the program, that the personal contact with the tutors every week, that I missed in my previous experience, because this contact with colleagues and with the tutor every week make you connected with the program. And
I think yes. Yeah, no, I think that's a really important point, that within the program there are a lot of what we call touch points that, yes, be it Ian, be it Colin, myself, etc., that you shouldn't ever have the feeling that you're undertaking, a big long program of study and you're on your own. You should always feel part of a group. We've got a lot of structures in place to facilitate the group feeling as though, you know, you're as close to being in a class on a campus as you can. How did you find, you know, you're a busy clinician. How did you find juggling the program, your family life, your clinical duties? How, you know, you've been at it for a year now.
Yeah, sure.
How have you survived?
What I like about the program also is it was designed for the Middle East. So you took in consideration all those break days that you did all the lectures on Friday on the suitable time. And which makes for us, sometimes we have duties on Fridays, but because it's flexible, we can easily adjust our practices to the program, because it's in a free day, so you can work in another day to swap with a colleague. And it is challenging, but because I see 50 diabetes patients per week, so this load motivates me more to understand their necessities. And the other part, that because we are in a group, we always chat with each other beside the program. Yeah. For example, Dr. Muhammad and me, we are in the same group where we work in the same center. So when we confront a very
complex
interesting case, then we exchange knowledge with Dr. Rashid. We are a reasonable group. So, and the other part was very good, that when we traveled to Kuwait 2 times, because there was a crash course for 3 days. We met you there, guys, and it was a very pleasant feeling to get a lot of information, and then it triggers you to be hungry for knowledge.
Yeah, absolutely. And of course, the incoming students now, we're going to be doing a lot of that kind of induction piece online, thanks to COVID-19. But you know, that's the beauty of a program like this, is you can do that. And I think that point around, you know, in the Middle East, the tutorials are on Friday. In Malaysia, they're on I think it's a Thursday evening. It's, you know, the ability to, and one of the things Rebecca will speak to is, by keeping the group size small, by keeping it that, you know, there's around 20 odd people in a group, you can adapt the program to the needs of that group specifically. And I keep going back to, you know, you get to know each other. You get to feel like you're part of something that's going through the experience together. And certainly I know, you know, when we've looked at how other programs are delivered, and they, you know, they either kind of present you with, here's all the material online and we'll see you for the exam, or they do these giant webinars where, you know, you'll have 50 or 100 people on a webinar and it's simply one-way flow of traffic. You know, we don't think that's the best way to learn. We're very strong proponents of kind of social learning, and of, you know, you learning as much from your peers and discussion with them as from the tutor. And what the group here probably won't see today is the degree of interaction that there is in the weekly tutorials. You know, the back and forth that we're having now is fairly reflective. You know, they're not kind of lectures at you. Is that fair to say?
I think if I might add something to I think for the group, I think we will help, because that it will be in India, so it will be the same time. I mean, this is the strength of the program. It's designed for different regions of the world, and what makes the participation easier. What I like also about the program is the technical part, that now we are reviewing the whole materials, the very precious videos that they are there, explaining everything. You know, we used to, I finished medicine long time ago, 25 years ago, and then there was no such materials, video materials elaborating the pathophysiology of mechanism, how the cells enters the bloodstream, you know, all those clots are forming. We knew it, but it's not as good illustrated as now, which make knowledge easier. So there is a lot of such videos.
Some of my favorite is actually on the retinopathy. There's some really cool 3D medical animations for retinopathy that, you know, it really brings it to life.
Yes, yes, absolutely.
Amjad, I suppose, is there any advice you'd give someone coming onto the program in terms of how to approach it? You know, I'm sure it's not all doctors on the call today, but like, take the assumption that everyone's going to be a busy clinician in some respect like you. What advice would you have for someone thinking about it?
My My advice is immediately when there is a question posted by the tutor, you need to respond immediately, even if you don't do the whole homework, because we know doctors are generally perfectionists. They want to prepare better, to know every detail. No, just share your knowledge, what you know, and then you will see that people will add on that. When you wait up to the end of the week to participate, it's a little bit too late, because you don't see the response of your tutor to what you have said. Because you might come with a brilliant idea, maybe it's a raw idea, not perfect, but it will be with discussion getting better and better. So my advice, share immediately what you know, read a little bit and add more and more further.
Yeah, that makes perfect sense.
Dr. Mina has raised her hand. Dr. Mina, do you have a question? Dr. Sharma? Mina? You've raised your hand there.
Hello.
Hi.
Hello.
Do you have a question?
Yeah, I am actually a health educator. So when I go to schools to educate, so there are so many questions regarding the diabetes. So anything would you like to throw some light on that?
Sorry,
well, we have had educators on the program before. They found it very informative, and we give I think it's very useful to have an overall background to diabetes. As Rebecca will be telling us shortly, there's 6 modules which cover a wide range of diabetes issues, and diabetes educators, I think, benefit enormously from the course. What do you think, Dermot?
Yeah, no, absolutely. I mean, the program is designed for a pretty wide spectrum of people that are dealing with people with diabetes, and certainly, you know, there's an entire module based on self-management of diabetes, which I think is, you know, absolutely bang on relevant to what you'd be doing. But having the detail around screening, diagnosis, having a really in-depth understanding of the medications and treatment options and the various microvascular and macrovascular complications, I think, you know, that's all extraordinarily important, as are things like travel, sports, you know. So for someone that's involved in education of patients, yeah, I can think of nothing better than to, you know, immerse yourself in this. Amjad, there was just one last question I was going to ask you, and it was around the academic piece. So, you know, the program is very practical in nature, and it's very much focused on clinical decision making, and, you know, can you give the best advice and guidance to your patients and work with them to manage their condition. But it's underpinned by, you know, the latest thinking in diabetes, be that, you know, ADA guidance or clinical trials. And, you know, you're going to be doing, you know, you've done a lot of reading of journals, etc. But you've also, you know, at this stage, you'll have written all of your essays, or 5 out of 6 of your essays. How did you find, as a doctor that's, you know, kind of 20 years out of medical school, how did you find returning to kind of, you know, that discipline of, I'm going to read up in an area and research it and then write about it? Was that daunting? Did you feel you got better at it as the course went on?
Thank you for this question. This is my one of my motivation to come to this course, because this was my weakest link in all of this. I always wanted to write something, but I haven't had enough guidance to do that. And one of the nice comments when I first started my first essay was a nice feedback from, I don't know, I can't recall the name now, that I wrote an essay as a narrative, you know, just like I'm telling a story. And then you see that every time you write a piece of text, then you get a good feedback. And I saw myself growing in writing skills and writing scientific writing, how to write it. It's simple sentences, of course, but still the whole context is getting better and better. Only one time I went very down. I had an annual leave August. So I scored very bad. I had no time just to finish on time. Luckily I passed, but after that the curve went up. So I'm very delighted that I did that. I feel much better and confident now.
Fantastic, fantastic. Amjad, I could stay chatting to you all afternoon. I'm very conscious of the time though, and that Rebecca and Colin need to do their pieces. So look, thank you so much for that. I think it's really valuable that people get an honest student perspective. So no, thanks a million.
Thank you for giving me this chance, and I wish all new colleagues, and you can always count on me if you need any support. Thank you very much. All the best. Okay, bye.
Take care. Just a bit of housekeeping again, everyone, just for anybody who joined late. If you want to turn on your camera, if you're in a good Wi-Fi or broadband area, you're very welcome to do so. It makes it a nicer experience when we can see you. Also, you are on mute automatically when you enter the webinar, but if you want to ask a question, you're very welcome to take off your mute button and ask it, no problem. Or you can use the chat button if you're feeling shy, or you can raise your hand. There's a little raise your hand icon there as well. So without further ado, I'll hand you over to Dr. Colin Kenny, who's the Programme Director.
Well, good afternoon, everyone. It's very nice speaking to you. I have a presentation for you this afternoon, essentially looking at the course, the program, and also a little bit of overview of diabetes in India currently. So I'm going to give you a little flavor of the course. I know in India, everybody prefers tea. When I was in India a couple of years ago, I had some really great cups of tea, but for the purpose of this, I'm going to give you a flavor of the course. It is a comprehensive course. It follows the International Diabetes Federation curriculum. We do cover type 1, but principally type 2 diabetes. We have experienced tutors from throughout the world. All of them have very lot of practical experience as well as academic experience in diabetes. We do tend to focus on what's important in the Asia Pacific region. We look at modern management, particularly about individualizing care. And I'm going to this afternoon give you some updates on studies and guidance. As you've heard already from Dr. Ahmed, it's an online format. It's flexible to work when you can. You can participate from your office or the place of your choice. There are weekly tutorials which are recorded and become available for interaction and motivation. Well, let's look at diabetes then. Here's a very striking leading article from Paul Zimmett, which is that diabetes and its driver is the largest epidemic in human history. I'm sure if you're working in India, you're very aware of that, but it's also a worldwide epidemic. I know we're living through an epidemic at the minute of coronavirus, but diabetes is prevalent worldwide. And India is no exception. You can see the population size and the number of people, this is 2017 data, who were living with diabetes. I guess if you're working every day in your practice, you must be coming across people living with diabetes. And this course is very well suited to help you with that challenge. So just to say then about diabetes in India, a bit more particular, you're projected to have 125 million people living with diabetes by 2040. There has been a very percentage growth, particularly in the last 10 years, particularly in women and also in men. And of course, the spend on diabetes is very high as well. However, I think it's interesting to reflect, and I ask my students to reflect on this, that it's not as prevalent in some states as others. And I think this is a very interesting point. They used to say that the north of India was more prevalent than the south. I think that's still the case. I think we could have a good discussion on why some states are more prevalent than others, and also why rural areas are less prevalent than urban areas, although that's subtly changing. Clearly, from the point of view of diabetes, Kerala is the least prevalent state, with some of the northern states such as Uttar Pradesh are very prevalent. And I think that's interesting, and it's maybe something that you could reflect on as well. We like to draw a line in the sand. We do a lot of teaching in the Middle East, and you know the diagnosis of diabetes, you do know the line in the sand is 6.5% or 48 millimoles per millimole. When we do the course, we tell you how to diagnose diabetes, the ways of doing it, and why this particular line was drawn in the sand, but you probably know it's to do with retinopathy being taken off at that point. We talk, of course, about the drugs that are commonly used. You'll be very familiar with these, often starting with metformin, then moving on to other agents, injectables, and the GLP-1s as well. We also, of course, tell you how these drugs work and where they work. This is a complex diagram I'm not going to go into just now, but as you might imagine, on module 2 of the course, we go into a lot of detail on this so that you understand and are very, very cognizant of the drugs that we use and where they work. You have diabetes guidance in India. I'm sure you're possibly familiar with it. This is the latest guidance I could find here. A lot of the guidances are very similar. I'm going to come back at the end of the presentation to the EASD-ADA guidance, but this is the current Indian guidance. All of the different guidances set targets, and this is a subject of very much debate as to what target is suitable. I think what draws them all together is that it's down to individualized patient characteristics, preferences, potential side effects, and cost, is how NICE and SIGN, the Scottish guidance, tell us how to set targets. And how we do that is you start with a problem, you develop a collaborative goal, and then validate their goals and plans. So it's very patient-centered, or expressed another way, no decision about me without me informing patient choices. Now, I'm sure you've also seen this need for an expert patient, because in any 1 year, you might have 3 hours with a healthcare professional, but the remaining 8,757 hours have to be managed, the complications themselves. So you do need to aim for an expert patient, and you need to be careful with the language you use. So if I'd been talking to you 15 years ago, I might have been talking about diabetics. Of course, we use the term people living with diabetes now, and we talk in a non-judgmental, reassuring way. We try to understand what they know about diabetes, and we use appropriate language. In other words, language does matter to our patients with diabetes. No doubt you will come across this, barriers to the use of insulin. And again, of course, a large part of our program tells you how to overcome those barriers, tells you when insulin is appropriate, and other injectable therapy may be more appropriate, depending on its availability. Of course, we deal with emergencies, both hypo and hyperglycemia. We tell you how to differentiate between those two emergencies and how to treat emergencies in general. We look, of course, at the cardiovascular risk associated with diabetes. We look at lifestyle, hypertension, lipids, glycemia, and how glucose-lowering agents, particularly the newer ones, can impact on cardiovascular risk. Urine is very important in diabetes, and we emphasize this a lot. There's reasons for this, but essentially, albumin urine, the ACR ratio predicts macrovascular complications. And for every unit of BMI over 25 kilograms, major renal events increase by 5%. Look at it another way. This is the NICE guidance on renal problems. You can see that you might have an eGFR of 48, putting you in a moderate risk of chronic kidney disease. But once you have significant albuminuria, then your cardiovascular risk and your risk of renal failure or diabetic kidney disease increase dramatically. Now I'm going to put you in a position here. Here's a Caucasian foot, admittedly, but you are working in your practice and the practice nurse asks you to see this foot of a person living with diabetes. Would this worry anyone that's in the webinar today? Anybody like to tell me what they see here? Anybody like to say that they would be concerned about this foot? I'll take a comment from anybody.
This is a foot ulcer, so for non-control of a diabetic.
Yes. So first of all, yes, we're looking at potentially a foot ulcer. Mohan, I'm going to stay with you and ask you what you would do about this foot.
Associated callus formation around it initially.
Yes, that's an excellent observation. You have noticed that first, even if it wasn't for this ulcer, here is a lot of callus formation. So already you're suspecting that this patient has some type of peripheral neuropathy. Quite right. Keep going, Mohan, and tell me anything else you observe.
He's a must need everything, everyday dressing is a must needed. And also regular checkup is for preventing of amputation in the future.
Yeah, there's a worry about that, isn't there? Do you notice a red area here? Would this worry you?
Yeah, under this little finger, probably this reddish bluish area, probably
Yeah,
the
this
ulcer.
reddish area of the, it's actually a little toe.
Yeah.
And
there could be some pus formation and this would increase if not taken care properly.
yes, absolutely, Ashish. And would you take a curette to this and see if you could get pus out of it?
Yeah, just repeat the question.
Would you take a curette to that area and see if you could drain pus out of it?
Well, as a physician, I'm always afraid to get involved with a curette or something. Probably
Well, you're
I
always
would
a very wise physician as well, because
antibiotics
I would be very concerned about
down,
the area.
then probably yes.
What would you do about this, Ashish?
I would not do it immediately. Probably not.
No, I think what we need to do is this patient needs hospital admission today. They will probably need, if they can get it, an MRI of their foot, because I would be very concerned about osteomyelitis here, as well as a deep-seated infection. Sure. They're probably going to need double antibiotics, and they're going to need, you're right, quite right, a surgical approach to this to see if they can drain pus out of this. So this patient's in a lot of trouble, is what I'm saying. And I suspect you think that yourself, Ashish. I'm going to look at some latest news and trials, if that's all right. I want to talk to you a little bit about the Dirac study, which is being conducted in Newcastle and Scotland here in the UK. Essentially what they've done in the Dirac study is encourage people living with diabetes to lose as much weight as possible by taking a very low calorie diet. As you can see, that has put people into remission, and this is really quite exciting. And on a 2-year follow-up, if you achieved a greater than 10 kilogram weight loss, you had a good chance of putting your diabetes into remission. And many people are quite excited about this. As well as that, we'd be talking to you about all these cardiovascular outcome studies. No doubt you go to diabetic meetings and you hear about these. There's a ton of them. I'm not going to go into them today. A lot of them reported recently in the last year or so, and a lot of them are ongoing, but they've had a big impact on what we decide to do about our treatment. This was the 2018 guidance, which has been updated just last year, and it has made us, and this is the standards of care from the American Diabetic Association. We use all this guidance to help teach you and train you about living with diabetes and the medication to use. But really, in essential terms, what they're saying is you should preferentially use a GLP-1 to prevent cardiovascular disease. Use an SGLT2 in people in heart failure. If there's established cardiovascular disease, consider a GLP-1. But if there is heart failure, consider an SGLT2. So that's bang up to date. With different glycemic targets we'll be telling you about. We'll be telling you how we use diabetes technology. We'll be telling you about cardiovascular disease, which I teach on. We'll be looking particularly at older adults and also the thought of de-intensification. Children and adolescents we touch on. Pregnancy, of course, we mention. And then we also look at advocacy and insulin access and affordability, which is a big issue everywhere in the world, particularly in the United States. Of course, your judgment is on an individualized patient. So we help to guide you as to how we can make make these judgments depending on the patient's state, their attitude, how long they've had the disease for, their risk of complications. So we get everything we do is informed by evidence, what the patient wishes, patient-centered choice, and then of course these new emerging cardiovascular outcome trials. We always start with type 2 diabetes with metformin because of the good evidence. However, if they have established cardiovascular disease, then preferentially, as I've said already, we use a GLP-1 or an SGLT2. If they don't have established cardiovascular disease and there's a need to minimize hypoglycemia, then we have a choice of DPP-4s, GLP-1s, SGLT2s, or TZDs. If we're worried about weight loss, or we want to achieve weight loss, then a GLP-1 or a SGLT2. And then finally, if cost is a major issue, then SUs and TZDs are the drugs of choice because they're generic agents. So that's in a big chart, very, very quickly, which we spend a full module covering in detail. But we also look at combinations as well. And this is what makes it interesting. Of course, what you can and can't use and which combinations. And I'm not going to again go into detail just now, but I reassure you that we do tell you all these combinations that are safe and unsafe. So should you consider the IHEAT diploma? I think yes. Diabetes care is changing rapidly, both in its demographics and its management. You're the ones that are delivering diabetes care, so have a responsibility to stay up to date. IHEAT offers a comprehensive, convenient way to update your skills. We ensure materials are relevant and updated, and we're just in the process of updating the whole modules. We work with you to develop your knowledge and skills. We support you with technology, learning, and motivation in a very up-to-date and IT-friendly way. Folks, sitting is the new smoking. So you've been sitting there for a fair while. I'm going to hand you over. Thanks for your attention. I'm happy to take questions now or at the end. Has anyone got any questions for me at this stage?
We
Mohan,
can't make
I'm
it.
really sorry, I can't get it, but I suggest, Mohan, that you maybe write it down in the chat. I look at it and I'll try and answer your question through a chat rather than a phone call. So Rebecca, at this stage, I'm going to switch over to you and let you give a presentation. Is it Rebecca or is it Dermot? I'm sorry.
It's Rebecca.
Good evening.
Rebecca.
It's me, thanks, Colin.
Hello.
Okay.
Is that Dr.
Hi, Dr.
Daz?
Daz, did you have a question?
Very good evening, sir. My question is whether this training session will include things related to dietary things, means selection of calorie, what type of foods. I'm asking related to the diet.
Yeah, okay, that's a very much frequently asked question. I have covered pharmaceuticals today. Diet is a very contentious area. What we've been doing recently is falling back on, again, ADA guidance, which is the guidance on nutrition and medical nutrition therapy. And we take you through that, we signpost that, but really, I think you'll find that people have a lot of difficulty making absolutes about diet. Other than we've had a couple of dietitians on the course, and universally they say to me, encourage patients to eat like their grandparents did.
Thank you.
Hello, Dr. Colin.
Yes, hello, Jersey.
Yeah, can you just brief about the role of diabetes with physiotherapy also? Can you have a correlational briefing on that? What's
Well,
the role of
physiotherapy,
therapist?
you have a very important role as physiotherapists, which is that, again, diet has been mentioned, but physical activity is absolutely critical in diabetes. It's very important for the patient living with diabetes to be physically active, both to treat diabetes and to prevent it. So we encourage all types of physical activity up to, 30 minutes a day, combined with an exercise program of weights as well. So yes, people are often referred to exercise physiotherapists to encourage with physical activity, which is absolutely critical to diabetes.
I think it's fair to say, Colin, that they don't know what exercise to undertake, and I think that's where that role particularly comes into its own, is giving them things that are achievable and accessible and gradually increasing them.
Absolutely, Dermot, I agree with you. It has to be tailored, just like therapy. Physical activity has to be tailored to the individual, particularly in societies where walking outside is difficult in heat, or where culturally it's not acceptable to walk outside. These are all issues that are frequently brought up in the course, but we always encourage people to find a solution to these problems, because physical activity is so very important to people living with diabetes.
What is the fasting rate and the postprandial rate? Usually in India, the fasting rate is 120, the postprandial 160. It is right.
I think, Mohan, you're going to have to talk to me by chat, and I will answer your specific questions.
I think that was about the cost. I will run through the program in its entirety now, and we'll go through the costing of the PGDIP and the MSc as well. So that might answer a lot of the questions. I will do it quite quickly because I'm aware that you're all very busy clinicians. So you can see my screen, right?
Yeah.
Yeah, super. So first of all, I will talk to you about the University of Warwick. The University of Warwick is ranked 10th in the United Kingdom and 62nd in the world. They would be renowned diabetes educator university in the UK. They've trained over 14,000 diabetes graduates in the United Kingdom. They're a member of the Russell Group, which is, I suppose, the elite research-intensive university group in the United Kingdom, including Oxford and Cambridge and all of the top-ranking research universities in the UK. They're world leaders in diabetes education and research, and they fully accredit our programs. So we are IHED, and we are the online program manager for the University of Warwick. You will see when you get communications by WhatsApp or by email from us, you will hear the word IHED. And you might wonder, how does that relate to the University of Warwick? So as I said, we're the online program manager for the university, for the medical school. We're an Irish organisation, and we deliver, I suppose, large training contracts with ministries of health and healthcare and governments globally, particularly in the Middle East and Malaysia and Asia. We have a strong focus on primary care, but that has changed hugely in the last few years. This is predominantly their family physicians and GPs on this program, but we do welcome all members of the transmural care team. So primary, secondary care nurses, pharmacists, dietitians, endocrinologists, cardiologists have all done this program in recent years. And for whatever reason, upskilling, as Colin so rightly said, there's so many new injectables and orals these days that there's a vast array of the transmural care team see the merit in upskilling. And we have over 300,000 course completions in the IHED platform, learning management system, and over 30,000 clinicians registered on our program globally. So like Colin has gone through this in detail, so I won't spend much time on it. You know the stats, they vary depending on who you look at, but unfortunately it does not make for very good reading irrespective. So at the moment it's between 77 and 85 million patients living with diabetes in India at present, and it will rise to over 134 million in the next 25 years. 1 in 6 adults living with diabetes in the world come from India. With that in mind, there's over 1.2 million deaths are attributed to diabetes in India on an annual basis. Now, there are only 65 places to train endocrinologists in India per annum for students leaving their MBBS or their MD qualification. And they say there's approximately 650 endocrinologists in the whole of India, and there is a need for 28,000. So that's a huge gap that exists. Now, this program does not make you a diabetologist. It does not make you an endocrinologist, but what it does do is make you an expert in your community in diabetes and bridge that gap between the need for a diabetologist and really serve the community and serve in either primary or tertiary care, where there's a huge need for an additional skills in quite a staggering pandemic. So that's just some of the stats. I know they're quite shocking, but they are a reality that reinforces the reason why it's so important to upscale in India and globally. I'm putting this in today because I think it's very important. You're taking the time out of your very busy day as a clinician in the height of a pandemic. This is from Medicine Sans Frontières, and it came out in the last few days. And I think it's hugely important to just have a quick look at it. It's the health footprint of the mortality and morbidity of COVID-19. What I want to draw your attention to is the third wave. What happens during a pandemic like COVID-19 is that something like the care of chronic illness and NCDs get put on hold. And essentially those who would have a chronic illness that would have normally have gone in for a hospital admission, it plummets. And then after the pandemic has passed, it soars. And as a result of that, the impact of interrupted care on chronic conditions is very, very extreme, and urgencies become emergencies. So it's very important that even supply chains get affected and insulin chains get affected in this time of crisis. But it's very important that we don't forget this for two reasons. Patients living with diabetes have a far higher mortality rate from COVID-19, and the impact of this interrupted care has very, very serious reaching, I suppose, impact and effect because they're not getting the treatment that they would normally get because they're in lockdown and they're looking after their own condition themselves. So it's a dangerous time for multiple reasons, and I thought it was very important to put that slide in. So next, the Master of Science in Diabetes Care is a 12-month program for the postgraduate diploma, and then an additional 8 months for the MSc, so it's 20 months in total. So you can start on the PG DIP, and if you're enjoying the experience, you're more than welcome to go on to the MSc, or you can sign up for the MSc immediately. So it's entirely up to yourself. We've full international accreditation from the University of Warwick, designed and delivered by world-leading diabetes experts. We're delivered on an advanced medical education platform and recognised by local regulators throughout the globe. So that's the Emirates Medical Association, Kuwait Institute of Medical Sciences, Dubai Healthcare Authority, the Malaysian Medical Association, Japan Primary Care Association, the Royal Australian College of General Practitioners. Obviously, it's recognised fully in the United Kingdom, Ireland and Europe. And it's also recognised, the University of Warwick is recognised on MOH and MOE registers globally across the world. We did in January 31st, we met with the Secretary General of the MCI to ask for accreditation for this program. He did say that because it's not a clinical program, he couldn't give accreditation and he would not do the same for it's irrespective whether it's online or face-to-face. It's the fact that it's non-clinical. So it's not a fellowship, and that would be the same. It's not about being international or local. It's the same answer, even if it was from one of the local universities in India as well. What he did say is he would provide a support letter, and that doctors in India are very welcome to display their MSc or their PG DIP in their place of work, in their clinic, and describe themselves as a diabetes expert. So that's very important, and I think it's worth noting. And that's Dr. Vatz in the middle, who's the Secretary General for the MCI. And that there on the right-hand side is the head of the Obesity Society in the United Kingdom, an associate professor in the University of Warwick, who does some part-time talks on the program as well. So just to give you an overview of what the learning management system is like, we have synchronized live tutorials, interactive case studies, tutor moderated discussion forums, innovative clinical assessment, advanced analytics to support students, measurement of competence, 3D medical animations, interactive quizzes. The reality is that, I suppose, the traditional distance learning is frightening because you're relying on yourself to be self-motivated, which for busy clinicians with not just huge clinical caseloads, but also family commitments, it's impossible to be self-motivated all the time. And so our program has so many touch points. We have the face-to-face tutorial every week. We have a huge interaction on the discussion forums with tutors. You get to know your mentors exceptionally well, but it's not that terrible. I've been in education for nearly 20 years, and I've seen some less than exemplary distance learning programs where you've got these terrible downloadable PDFs and talking head videos. And this is not this. It's highly interactive, very palatable. You have 3D medical animations, you have your interactive quizzes, your hot topics. It's just very, very complex information is given to you in a very palatable format. And I think that's very important because you can walk through the program in an easy and enjoyable way. And there's a huge collegiate feeling in the program because of the face-to-face tutorial on Zoom every week, like we're having now. The clinicians on the program get to know each other very well. They set up WhatsApp groups, they ask each other about patient cases, and they just get a very, very strong sense of a collegiate environment that you would do in a face-to-face setting. So I think it's very important to point that out. Our international faculty, what I will say is we do not just take from the University of Warwick, we take world-leading global experts in diabetes care from across the United Kingdom, Ireland, the United States, the UAE, Australia, India. Anywhere we go, we do not just cut and paste the same program for every region. As Dr. Amjad was saying from Qatar earlier, we tailor it and we bespoke it for every single country that we're in. We understand that certain medications will be used more than others, and prevalence and availability will be used. There's a certain, I suppose, genetic predispositions that come into play. And as a result of that, we hire local tutors, experts and leading experts in the entire country. And we do that and combine that with global leaders to make sure that we absolutely are giving you the best possible education. So Dr. Colin Kenny, who has just spoken, is our program leader, and he is very modest, but he has received a Medal of the Empire Award for his contribution to diabetes care in the community. And we're very proud to have him as our director. He's past chair of the Primary Care Diabetes Society. Dr. Martin Hadley Brown is from the University of Cambridge and former chair of the PCDS. Dr. Stephen Lawrence is the internal professor in the University of Warwick, and he's a program lead in the University of Warwick. Dr. Mohammed Fargali is in the UAE and will be considered one of the foremost leaders in diabetes care in the United Arab Emirates. And Dr. Katie Reid in the University of Manchester, and she would be considered a foremost expert in public health and patient change in a clinical setting. So I'm just going to run through what the program entails for you. The first module is core principles. So obviously it's screening, epidemiology, pre-diabetes and classification. Module number 2 is most of the feedback we get from the doctors is this is by far the most intensive module of the 6 modules of the postgraduate diploma. So you'll do everything in treatment from the NCD model and chronic illness model all the way up to your medicinal interventions, your orals and your injectables, and pump therapy, and in extreme circumstances, weight loss surgery also. So it's a very intensive module. And next, and this is the one that the doctors say that they enjoyed the most, and the participants on the program enjoyed the most, and it is the self-management module, where you are taught how to empower your patient. As Dr. Kenny said, you've maybe 3 hours per annum with a patient living with diabetes, and they have the over 8,500 hours living with themselves. So it's about empowerment, it's about having an expert patient, it's about, in the UK we use a phrase, no decision about me without me, and for the patient to really take ownership and responsibility for their own condition and work with you as the clinician to better their patient outcomes. So on the 4th and 5th module is the microvascular and the macrovascular complications, obviously extremely important and will dictate what type of medicinal interventions you use on your patient. And finally, we finish off with special circumstances. We look at, in the Middle East, we look at Ramadan and Hajj, but in all countries, if there is religious fasting, that can have an extreme effect on both hypo and hyperglycemia. We look at sports and travel, mental health. You're 3 times more likely to have mental health challenges if you are a patient living with diabetes, and we teach you how to look at the flags and the alerts with your patient who may be experiencing those type of challenges. And also, of course, in older people, you have comorbidities and multimorbidities and medicinal interventions you need to use in those circumstances. So if you're not sick of us by all of that and you finish the postgraduate diploma and you want to progress onto the MSc, there's an additional 2 modules on the MSc. So the first one is your research methodologies. So that would be essentially choosing what topic you want to do for your professional project, and you do your quantitative and qualitative analysis. And then finally, it is your professional project. We're very, very excited about this MSc stage of this program because you don't just do a thesis that's going to sit there and gather dust in a university, never to be read by anybody but you and your supervisor. The outputs for our MSc are very different, and we're very excited about that. We do ask you to do a poster presentation in a medical conference, and then a journal submission to a national or international medical journal of repute. So you'll be taught how to really create a journal submission of a very high standard. And should you be published, there are multiple benefits to that. There's benefits to you, that you would put that to your CV and your biography, which is very strong. And then there are also the fact that you are giving back, and we as the University of Warwick are giving back to the research community and giving back, I suppose, from the professional project, your clinician and your patient experiences. And that in itself is very holistic and circuitous and giving back to the research community and growing the reputation of the program. So how does it work? Normally, as Amjad said, we have face-to-face workshops in every single country that we launch the program in. And we did intend to do one in India at the end of May, but obviously because of COVID-19, that is not feasible. But please be fully aware that you will be at no disadvantage whatsoever. We will do a full online orientation where we'll give you how to use the LMS, the Learning Management System, work online, use all of our interactions, get to know your mentors, get to know your tutors, and you'll be at no disadvantage. And hopefully we will be able to meet face-to-face in the November face-to-face workshop for your second intake. We do pride ourselves on the face-to-face workshops because it's a wonderful experience to get to actually finally meet all of your colleagues in person and your tutors in market. And I think it's in terms of understanding the more pragmatic and practical areas of the program, like interpreting retinopathy scans and your insulin therapy and your pump therapy, and just getting to know each other. I think it's nice to meet face-to-face at least once during the program before your convocation. We do have the weekly discussion forums. That's where the tutor throws out a topic for that week, and it will cover your learning outcomes for that week. So you look at a particular case of an individual with HbA1c, and they would have whatever BMI and whatever multimorbidities, and you'll discuss exactly that particular case topic for the week in the discussion forum, and you'll be giving reading and links to reading that you will look at for the discussion forum. And that culminates at the end of the week with the weekly live tutorial in Zoom, exactly like we're doing now, but it's a lot more interactive. It's not didactic. We do not just talk at you as we're doing today. It's very discursive and all peer-to-peer discussion and learning through the case studies. And finally, the continuous assessment. You must submit a 2,000-word essay at the end of each of the 6 modules of the PG DIP. And at the end of each semester, after 3 modules, you will have your online examination, which is can also be done from the comfort of your home in an online proctoring system. So you can do all of the program in your own pace at your own time. And I think that's very important for busy clinicians. If you were to miss the live tutorial that will happen every week, we do record them, just like we're recording this session. So you can download it and watch it. You don't even have to download it. You can watch it at any time you want if you are too busy to come in person. But we strongly advise you try and get as many tutorials as possible. So this is what the platform looks like. It's highly interactive, as I said. We base it on case study learning. And this is the live tutorials once a week on Zoom. Program impact, I love this slide because I think it's hugely important. This is essentially the purple line is the confidence levels of clinicians before the program, and the green line is after the program. So they go from anywhere from 40 to 50% up to 100% after the program in confidence levels in anything from prescribing CVD prevention in type 2 diabetes, initiating GLP-1 agonists, identifying emotional distress in a young adult with type 1 diabetes. So it's superb at really improving your clinical confidence levels. To delve deeper into this, and this is based on surveys from all our existing students and alumni, they said that the quality of patient care has improved by almost 80% after doing this program. Their career has improved, there's some positive impact, and that's very much about being considered an expert in their community. We have, our graduates have gone on to be academics in a university setting and diabetes experts. We have some of our alumni who've gone on to be on national committees, therefore steering the political and national agenda for diabetes care in their country. So they're hugely influential, and we're very, very proud of what our alumni have achieved to date. The reputation increases, and of course, understanding research papers and clinical trial results. So it's very important because there are so many clinical trials these days, as Colin so rightly pointed out. So the student experience, 280 plus students from 25 countries. We have 88% student engagement, which is exceptionally high for an online program. There's 100% positive feedback from program support and organization. And we have a 92% pass rate. I always say that this is not indicative of us being easy markers. It is an indication of just how passionate the clinicians are who do this program, how professional they are, and how much they understand how important this program is to their career. So that's why our pass rate is so high, and we're very proud of that. And the fact that a lot of us, the vast majority, it's 70% on continuous assessment and 30% on the exams. So it can be done once again in your own pace, in your own time, without having to worry about just an exam. So the most important is the program fees. I think this slide is quite busy, so please excuse that. But the overall postgraduate diploma price is €9,950. It's extremely high across the globe, and it's 7.8 lakh. But we have taken the initiative and the decision to reduce it for India and our inaugural launch India. So there's a 25% bursary, and there is an early bird up until the 29th of April. And that brings the price down to €7,000, which is 5.5 lakhs. So that's a huge reduction. The fee for the MSc is usually €4,500, which is 3.5 lakh, but we have also taken the decision to reduce that. So it's 2.5 lakh. So in total, the whole program has reduced from 12 lakh to 8 lakh to do the MSc. So in no other jurisdiction have we given such a huge bursary, and we think it's really important because we understand the challenges locally. And you do not have to pay upfront. You can pay by semester, or you can pay in monthly installments. So you don't have to worry about an upfront cost. So once again, that is very, very important. And you can do, for the whole program, you can do it in monthly installments. After this, we have our education advisors who will reach out to you personally, have a quick call, and ask you if you want to proceed, and they can explain in more detail about the payment options. But this is, as I said, top 10 ranking university in the UK and 62nd in the world. So they are extremely prestigious. And to do the same program in the University of Warwick would cost 24 lakh. So you get the exact same qualification without having to fly and spend 2 years accommodation and travel expenses to do the exact same program. So it is considerable bursary. And that's a summary. So it's a 20-month MSc. It's awarded from a top 10 UK university. Just because we are distance learning on this program does not mean we just take as many students as possible. We limit the places to 25 places per jurisdiction that we're in. So it is on a first come, first serve basis, and we have huge demand for the program globally. So just to be very clear, we do have limited places and they're filling fast. And it's designed to fit around your very busy schedule, as we're acutely aware and sympathetic too. So you can come on and look at it at any time. So that's it. As I said, our education advisors will be reaching out to you after this by phone call in the next few days, just to ask if you have any other questions and if you'd like to proceed with application. But right now I can open to the floor. If you have any other questions, as I said, your mute button is in the bottom left-hand corner of the screen, or you can just give a chat, which is the little chat button in the center. So you're very welcome to do so. Is there any questions?
Yeah, Rebecca, good evening.
Yes, doctor.
Yeah.
Hi, doctor.
Dr. Ashish. Yeah.
Hi,
Basically, I want to know that, see, I've been practicing diabetes for now almost 20 years.
Excellent. And where are you based in India, Ashish?
Delhi.
In Delhi. Okay, excellent.
Yeah. I'm in central Delhi, very close to the old Delhi area.
Okay, excellent, excellent.
So I just wanted to know that I've been treating these patients for the last 20 years now. And do you really think that this program is going to be a good help to me as a clinician?
Yeah, Ashish, just to be very candid, you sound like you are an expert already. So that you know, you've been treating patients for such a long time. What I will say, and is what Amjad said as well. He graduated nearly 25 years ago. The most important thing he found was the new treatments, new clinical interventions, but also the patient management he found very useful. In terms of patient change and learning how to clinically motivate an individual to try and look after their own condition in your absence. So there are areas like that that he felt were hugely beneficial. And those who go on to do the MSc, you can get published. And I think to be a published clinician can really increase your own CV and your own background and your own biography. So from that perspective, I think even to have the ability to put a top 10 UK university certificate on your wall gives additional weight.
I think, and Colin, jump in here as well. I think we're continually surprised when, you know, first of all, the average age on this course is early 40s. So most people, you know, they have 15 years practice at least behind them. And most people are dealing with diabetes patients every day. The most common thing we hear is about midway through module 2, the participants on the program start telling us just how much the program is changing, how they're delivering patient care. And we've had that every year since 2016. So I think irrespective of how long you've been managing patients with diabetes, an awful lot.
Ashish, one of the things that does surprise me as a tutor is the number of people like yourselves who are on the course. In other words, have a lot of experience, but do benefit a lot from the course. Of course, there's another element as well, which is a person like yourself is very encouraging to other participants. So they learn a lot from your experience. But I'd have to agree with Dermot, universally, mature doctors like yourselves praise the course because of the discipline required to bring yourself up to date, and also the writing required as well. is a very good discipline as well.
Okay. I get your point.
Do you have any other questions? Anybody else have any other questions? I know we went a bit over, so apologies for taking up that amount of time. I think it's very important to give you as much information as humanly possible about the programme. As I said, our education advisors will reach out to you to ask if you'd like to progress and if you have any other questions, and we're more than welcome to be flexible. And if you have any other questions as well, you're very welcome to reach out to the rest of the team. We do have Indian doctors on the programme, predominantly working in the Middle East, but have done very well. We've had a few doctors from Trivandrum Medical College in the south, and some excellent Indian doctors already on the programme. So we're delighted to have them.
Hello. Hello.
Hi.
Hello. Madam, hi, Madam. So Dr. Sandeep Mehta from Delhi.
Hi,
I want to know one question, because I am practicing for the diabetes for the last 20 to 25 years in Delhi, right? What is the problem in India, in fact? Because there is the one central body that's called as the MCI. Okay.
Yes.
And in the Delhi, and in the Delhi, the local body is the DMC, that's a Delhi Medical Council. One thing is that because that's a foreign degree, and that is affiliated with a college or the university from the UK, but that is not recognized by the MCI or the DMC. Without registered in the DMC or MCI, you can't write down even on your board, on your prescription, that you are such a specialist in the diabetes, and you are having such degree in the diabetes from the such university in the UK or the US or whatsoever in the abroad. Okay, so what they are considering, in fact, any degree from any abroad, if that is not recognized by the MC or the local body DMC, you can't practice in that. If it is the super specialization, or it is whether it is the is the post graduation and something else, etc. So many. So
Sandeep,
what to do in such case?
Absolutely.
Yeah. Because that is a very good program. I listen very carefully. Your whole program.
You raise a very important point, and what the MCI have made very clear to us is MCI recognition is for clinical postgraduate specialism. So, you do a residency program in surgery, and you then go on to do a fellowship in cardiothoracic surgery. You do a residency or fellowship in endocrinology, etc. And they are programs that have a clinical supervision over a number of years. No academic program in the world, be it Indian or be it from a foreign institution, has that clinical supervision element. Therefore, the MCI will not this could come from Harvard, and the MCI wouldn't recognize it. It could come from Amrita University. They wouldn't recognize it because it's not a clinically supervised program. However, they have said they are absolutely delighted for Indian doctors to take the program. They fully support the program. They're giving us a letter in writing to confirm that. And they are very happy for people that have undertaken this program to do exactly as you say and promote themselves as a doctor that has a specialty.
So the problem is not in that. What is the problem? In fact, you have to understand all these things, because when you got any litigation in the court, okay, and that you are having that such a specialization from the foreign countries or the foreign university, and that is not recognized by the MCI. Definitely, that's a Indian and court, and that's a Indian MCI or the whatsoever the bodies in India. They will not consider you you are specialized in the diabetes from any abroad countries, because of what they are saying. They are saying if you are having something course, because in India in the diabetes only the one course is there, that's the DM, endocrinology, right? There is no specialization course as such in my knowledge in India only for the diabetes. Okay, what's in the UK you have started, this is a wonderful program, really very great. But that's the problem in India, in fact, because they are not going to consider it in any court. If you got any litigation in the court, you will be in the problem otherwise.
Yeah, well, Sandeep, you're
definitely they will
absolutely...
at that time MCI will say, because okay, we are thinking for that, we are saying for that, but where is the written consent from our side that we have approved this program? So what to do in that case?
Yeah, you're absolutely correct. You will not be termed a specialist. You cannot call yourself a diabetologist or an endocrinologist after completing this program.
Yeah,
but
definitely.
You can call yourself an expert in diabetes care. So there is a small difference, but there is a difference. We can't give you a specialist qualification without clinical oversight, as we're not able to do that. But the MCI have said they will support the program, and you're allowed to display your qualification, and you can call yourself an expert in diabetes. There is a difference, and I know in India, I've been there over 50 times, I know it exceptionally well. I know that there is, sometimes some doctors will call themselves a diabetologist when in fact, you know, they may not be entirely a specialist, even though they have years of experience. So we cannot say you call yourself a specialist, but we can say that you will be an expert in diabetes and you can display the qualification. So that's what the MCI have said to us, and that's why we specifically went to meet the Secretary General, just to get clarification on that. You do know, and I'm sure you're aware, if you were doing a fellowship in the United Kingdom, there's 5 countries that the MCI automatically recognise for graduate qualifications, and the UK, New Zealand, Australia, Canada, and America are on that.
Absolutely.
List. But it is, of course, for a fellowship, for a full clinical fellowship rather than a graduate program, a graduate taught program, irrespective of whether it's online or face-to-face. So there is of course, there is a difference between a specialism and an expert, but that's all we can offer in an online setting. But you know, as I said, there is... Sorry, Dermot, as I said, there's 650 qualified endocrinologists in India, and there's a need for 28,000. So that is so extreme that expertise in the area and qualifications in the area, irrespective of whether it's a full specialism, are absolutely needed. You know, just because of it's such a huge critical disease and chronic disease in India and globally. Definitely. So as you said, you just can't meet it with 65 students on one program per annum. It's impossible. Yeah. So are there any other questions? You're very welcome, Sandeep.
No, not any questions. Thank you.
Okay, that's great. Well, as I said, we have this recorded and we will send it out to you again if you're very bored and want to watch it again. But our education advisors will reach out to you and give you a call and see if you'd like to progress. So thank you so much for your time, and best of luck with your lockdown. Be assured that we're all in the same isolated world, so we're all the same. So yeah. It's crazy, it's absolutely crazy. So I hope you stay safe and healthy, and we hope to hear from you soon.
And we wish same for you also, and for you all persons.
Thank you very much.
Thank you so much.
Very much.
We appreciate it.
Thank you. Thank you.
Take care.
Thank you.